Yes, sir, I'm just doing that. So, good morning all. Today I'll be giving a small brief talk on a OPD evaluation and indoor management of oral cancer. Mainly, I will be focusing on oral cancer patients. So, to begin with, OPD evaluation, why is it important? Because it helps us in the reaching a diagnosis of the patient, establishing a therapeutic relationship with the patient and the relatives. It's important to address their acute intervention needs and to outline and initiate a plan for further diagnostic workup and treatment. So we have to mainly consider 10 key tasks while doing an initial OPD evaluation. So we take the history of present illness from the patient. We do a thorough head and neck examination. We establish a risk factor, that is the etiological profile. We assess their medical and functional status, and we recognize the and address the needs for urgent intervention, like if the patient has got any airway obstruction or any like bleeding because of the tumor, or he is in a very severe pain state. So all those needs need to be addressed. Then we have to take a biopsy of the patient for histological diagnosis. We have to recognize the patient concerns, have a word with him, what problem they are facing. We have to do imaging and laboratory studies for further management. We have to initiate a multidisciplinary board review. So if we need to take any second opinions or to take any reference of other specialists, we have to do that. And we have to identify next steps in management. So these 10 key tasks need to be kept in mind. So to begin with, we first take the demographic details. So the name, age, sex, the residence of the patient, occupation and performance status. Residence is important because we know that many common cancers are seen in different states of India. Like you must have all heard chutta smoking, which causes reverse palatal smoking, which can cause palatal cancers. It is more common in states like Andhra Pradesh. Then the UP, Bihar belt and all, they use this chewed tobacco, khaini and all, which they keep in the GBS, because of which they have more buccal mucosa and GBS cancers. More like sex is important because nowadays you see a lot of tongue cancers in females. They don't have any habits, but because of sharp tooth and maybe because of spicy food, they are more prone to it. Then performance status. Performance status is donated, like you noted, with use of two grade scales. One is Karnofsky's or ECOG grade. So Karnofsky's is scored from 100 to 0. So 100 is a completely normal patient, mobile, while 0 as you go is like it's a complete dead patient, while ECOG is from 0 to 5. So ECOG 0 is a fully active patient who is able to carry on all his daily activities, while 5 is a dead patient, 4 is moribund. So this is the whole scale which you all need to know, and you have to note down when a patient comes in. So that's the first part. When you see the patient entering the room, you can take an assessment of how his general condition is. Then coming on to chief complaints. So for any oral cancer patient, the general symptoms which they can present with is any ulcer or growth in the oral cavity. They can have a localized pain, bleeding or oozing from the tumor, or a neck swelling because of neck nodal metastasis. Particular complaints related to specific substrate. So tongue or flora of mouth can have pain in the ear, which is a referred otalgia. You can have excessive salivation or foul smelling discharge because of secondary infection. Then you can have difficulty in speaking and swallowing. So this can note that the tumor is involving the muscles of the tongue, because of which ankyloglossia might be there and you might be difficulty in speaking, and change in voice. So if it reaches the posterior third or the base of tongue, you must have heard hot potato voice can be there. So that gives a clue that the tumor is going posterior. And in buccal mucosa or GBS cancers, there can be decreased in mouth opening, which can be due to the involvement of the muscles of mastication, any redness or ulceration of the skin because of lateral skin involvement, and loosening of teeth, which can suggest that there can be cortical erosion and involvement of the lower alveolus. So referred otalgia, so you must know the referred pathways of why this pain is there. So pathology of generally the floor of mouth or oropharynx involves a lingual nerve through which through the gasterine ganglion, which is a ganglion of the trigeminal nerve. It can then go relay through the auriculotemporal nerve, which supplies our external auditory canal. So like that, the pain can be there. In pathology of the oropharynx, that is the base of tongue, we generally consider through the trigeminal nerve into the petrosal ganglia, and from there to the glossopharyngeal nerve, it can go to the Jacobson's nerve, that is the tympanic plexus. So it lies on the promontory. So you have got a deep-seated earpiece. While in the floor of mouth, it is more in the EAC. And finally, in hypopharynx, it's due to the vagus nerve. So the external or internal branch of superior laryngeal nerve, it relates to the jugular ganglion and then through vagus nerve to the ulnar. So that is more in the posterior part of the pinna where the pain is seen. Then coming on to the history of etiology or risk factors. So first we have to very important to take the history of tobacco consumption, note down the frequency, the quantity, duration, all the details of smoking. You have to calculate the pack years. Then the history of alcohol intake. So you have to again mention the frequency, quantity, duration. Then there's an important factor called conversion factor of alcohol, which I explained in further course. Then repeated trauma or sharp tooth history you have to take, and ill-fitting dentures. So oral tobacco, there are multiple forms which so you can have it mixed with betel leaf, lime, and areca nut. So that you call they call it as pan. So the why does it more cause it's carcinogenic because it lowers the pH, which accelerates the release of alkaloids, which are carcinogenic. Then pan is also associated with oral submucous fibrosis because of the areca nut. BD smoking, it can cause cancers of the oral commissure, oral tongue, and base of tongue because of the particles. It's like BD is more likely to cause oral cancer than your cigarettes. Then chutta is associated, as I said before, with cancer of heart, palate, and palatine arch. And khaini is a mixture of tobacco and lime, which is retained in the inferior GBS, which can cause cancer of this site. So pack years is calculated by multiplying the number of packs of cigarettes smoked per day by the number of years the person has smoked. So you can say that one pack here is one pack per day for 1 year. So that is equivalent to one pack per day for 365 days or 365 pack years or 365 packs, that is 20 cigarettes. There is generally 20 cigarettes in a pack. So patient has approximately smoked 7,300 cigarettes in a year. So that is one pack here. And what is now conversion factor? So alcohol conversion is the process of comparing the alcohol content in different types of alcoholic beverages. So it's different if a person takes beer or whiskey or wine. So the alcohol content in each of these beverages is different. So you should know what type of beverage he is taking. So to help you easily compare the alcohol content, so we generally say that 12 ounces of beer. So beer has got 5% alcohol by volume. So that is considered as one standard drink. While as if you compare with wine and whiskey, wine has got 12% alcohol by volume, while whiskey has got 40% alcohol by volume. So only 1.5 ounce of whiskey is equivalent to 12 ounces of beer. So if a person is consuming whiskey, he is having more alcohol as compared if he is having beer. So by knowing different type of beverages, one can make more informed decisions about what and how much to drink. So this can help one avoid overconsumption and reduce the risk of alcohol-related problems. And studies have shown that more than 20 pack year smoking has shown to be predictive of cancer or, outcomes, both in patients treated with mostly with chemoradiation. With surgery, we don't have so many studies, but for chemoradiation, it has been seen. Then we take history of complications of metastasis. So you have got the most common cough and pneumoptosis because of the lung metastasis. You have got bone pains and weight loss. So weight loss should be demonstrated both in percentage of overall body weight loss and in kg. Then you take history of any previous treatment taken. So any surgery, chemotherapy, radiotherapy, all this details should be noted. Family history, personal history, past history, all should be noted. Past history, like any history of any other surgery or his comorbidities, because that's all is important when in his further management. General examination is like any other patient, so all his consciousness, cooperation, his build, his ECOG status, again, his temperature, BP, vital should be recorded. Pallor because of his first of all malnutrition, as well as because of any oozing continuously, his hemoglobin can be low. Then icterus, clubbing, and any generalized lymphedema. So specifically coming to intraoral examination, the tumor can arise from these seven subsites of the oral cavity. So lip, hard palate, buccal mucosa, retromolar trigone, the gingiva and the lower alveolus, oral tongue and the floor of mouth. Before we do the intraoral examination, we have to see the mouth opening. So trismus, always mention the inter-incisor distance in centimeter and not by fingers. Grade the severity of trismus. Correlate clinico-radiologically the cause of trismus. So you should know why the trismus is happening, whether it is long-standing. So that can be because of submucous fibrosis, while acute can be due to pain or because of infiltration of the pterygoid musculature. And in severe trismus, you should keep in mind that we might require an examination and anesthesia. So if it is because of pain during anesthesia, that the mouth will open better, so we can know the extent of disease better. Or we can use a 0-degree rigid scope. Like if it is because of fibrosis, his mouth opening is not going to improve even after anesthesia. So in those cases, a 0-degree scope can be put inside his oral cavity, and that can be helped to ascertain the local extent of disease. Then we come, these are the gradings. So generally there are two types of gradings, one in a dentate patient and one in a edentulous patient. So more than 35 millimeters inter-incisor distance is considered as a normal, that is 30, no trismus. While as you it become more severe, we less than 15 millimeters is considered as a most T3. And in edentulous state, it is more than 41 millimeters for a 0 and less than 25 millimeters for the grade 3. So what are the characteristics of the malignant ulcer? So you have got raised, it generally present with raised edges, necrosis at the base or in the center. There is induration surrounding which you have to palpate, and that will be the complete extent of the disease. It bleeds, generally bleeds on touch because of neovascularization, and it tends to have irregular margins. You have to explain the subsite involved, the size and the extent of disease. So coming to specific subsites, so this is how you explain. So in a buccal mucosa and GBS cancer, you have to anteriorly tell how much distance is from the commissure, posteriorly the distance from the retromolar trigone, and if it is going further posteriorly, how far it is reaching, like it is whether reaching anterior tonsillar pillar or the tonsil. Superiorly from the superior GBS, like vice versa, inferior GBS, coming on to the alveolar gingiva. Then anterior-posteriorly, you have to say from which teeth to which teeth is involved. So, with all these factors, the person in front will get an idea of the whole tumor extent in his mind. Then medially, whether it's coming onto the lingual surface of the mandible or floor of mouth. And finally, laterally, the skin involvement. So skin involvement can be like a exophytic and proliferative grow involvement, or it can be like skin puckering. So in this is it's important to ascertain how we have to find whether the skin is involved. So this is a small video. So many times patients in the OPD, because of pain, they may not allow us to bimanually palpate. So we have to know where the skin can be involved. Never palpate it in this way, because in what happens, the proliferative growth inside, it tends to push against the mandible. So then you feel that the skin is involved. But if you bimanually palpate inside, so you can see, put a finger inside, separate the tumor from the skin, and try to palpate it from outside. So there, in such cases, you will know where the skin is not pinchable between the tumor and the outside skin. Then that area of skin is only involved. So this bimanual palpation is very important to ascertain the skin involvement, and not just unilaterally palpating it from outside. Then coming on to tongue and floor of mouth cancer, similarly, anteriorly the distance you should tell from the tip of the tongue, posteriorly the distance from the tonsillolingual surface. Superomedially, the distance from the midline. The inferolaterally, the distance from the floor of mouth and the alveolar gingiva. The your important thing in tongue cancers is whether you can palpate the depth of the tumor. That is important. And whether there's presence of ankylosing or no. So this is because there can be involvement of the extrinsic muscles, or there can be also involvement of hypoglossal nerve. So the neurovascular bundle is involved, which causes fixity of the tongue on one side. So what is the difference between depth of invasion and tumor thickness? So you should all know that. So depth of invasion is only from the basement membrane to the deepest point of infiltration. While tumor thickness we take right from the exophytic growth and to the deepest point. Depth of invasion is now included in our staging, so it is important. So this ICOR study was there, which is a retrospective analysis of 3,149 patients. So they showed that depth of invasion was significantly associated with disease-specific survival. So hence this was incorporated into our AJCC staging. Then coming on to upper alveolus or palatal cancer. So anteriorly, you have to say that the tumor is reaching adjacent to which tooth. Posteriorly, the junction of hard palate and soft palate, and beyond, if it is involving the soft palate. Medially, the distance from midline. Laterally, from the alveolus and the buccal mucosa. And you have to also check for sensory loss over the cheek and forehead. So in perineural invasion of maxillary nerve, there can be loss of sensation. Then neck examination. So as we know that is the single most important prognostic factor. So you have all the lymph nodes, like how last time Kanav explained, each level, especially to the achillon nodes. So as we know, buccal mucosa GPS tends more to 1B and tongue can go more to level 2. But that is generally theoretical. We have to try and look for all levels of nodes in every patient and look for presence of clinical ENE. So clinical ENE can be because of skin involvement or because of the involvement of the sternocleidomastoid and you any very large node which is having restricted mobility. So in those nodes, we'll say that clinically there is extranodal extension. So further workup, so you have to do a biopsy. Biopsy can be punch or knife biopsy. Avoid just brush biopsy or scrape cytology. Then FNAC from suspicious neck nodes can be done, but generally if we have a frank growth and biopsy can be taken from the growth, we generally avoid doing FNAC from suspicious neck nodes. Then radiology. So depending on the subsite, so if it is a gingivobuccal cancer, we prefer to do a CT scan, but MRI can be done in few indications. So what are those indications? We can, when the bone is involved clinically, we can see that it's a growth of the lower alveolus and marrow is involved. So in those cases, to see till where the marrow is involved, MRI is better. Then second is perineural invasion and in high ITF cases. So with the soft tissue extent of the disease is better known with an MRI. And in tongue or floor of mouth, we should generally go for an MRI to look because muscles and soft tissue delineation is better. And PET scan or CT thorax can be done for distant metastatic workup. So generally, if we are doing a CT scan, we do a CT thorax with it easily. Otherwise, even a PET can be done. If a patient has got large N3 nodes, multiple levels of nodes involvement, lower neck nodes involvement, or if he's showing any signs of distant metastatic workup like bone pain or any like jaundice, icterus. So in those patients, we should do a PET scan. So punch biopsy or knife biopsy. When do we do punch and when do we do knife biopsy? Punch biopsy is generally done in well proliferative exophytic growth where we can easily take a punch from the growth. So as we say, the important points to note are one is the biopsy should be done from the representative portion of the tumor. So the necrotic portion should be avoided. Generally in the center you have got necrosis. So the yield of that biopsy will be less if you take from the necrotic portion. And why we say that a portion of normal mucosa also should be involved? That is because the pathologist can comment on invasion better. And if it is a infiltrative and ulcerative growth where there is no proliferative component, in such cases, as you can see on the right side of the picture, we should do a knife biopsy where we have to take a sufficient amount of deep tissue so that they can comment on the invasion. Then imaging checklist. This would be further lecture would be taken on this by Aditi. So in short, we have to look for the primary extent of the tumor, where it is reaching bone involvement, ITF involvement, the depth of invasion, and neurovascular bundle involvement. Nodes, nodal status, any metastatic nodes, ENE, relationship with great vessels, and distant metastasis. Finally, you all have to do the TNM staging. It's very important. Give a clinical radiological staging. If imaging is available, then you take help of radiology, or at least you give a clinical staging of what is the stage of the disease before we proceed for further management. So you should all know the AJCC staging, the final 830, and stage it as whether it's an early cancer or an advanced cancer. So that you can prognosticate the patient and explain him in short the details whether he will require a single modality or a multimodality treatment. Now, coming on to the indoor management. So, surgery for head neck cancers in itself is a complex. We all know that it's a very lengthy procedure. Sometimes it can take 8 to 10 hours, and also involves alteration of the anatomy and physiology of the upper aerodigestive tract. So, the management generally involves airway management, tracheostomy care, wound care, nutritional support, to name a few. Free like a flap with microvascular anastomosis. It also requires close monitoring because it can have microvascular failure. So this whole after surgery, the post-operative care, it's a healing process. So you have got from the day zero. Generally, patient stays till day 6 or 7. So the day 0 or 1 is a ICU stay where the patient can generally have immobilization, which reduces the mechanical disruption of the microvascular anastomosis, as well as allows for more invasive hemodynamic monitoring. And day 2 to day 6 is a ward stay. So you divide your management into ICU stay and ward stay. So there's an important checklist you should follow during your ICU management. So one is airway. You should assess the airway patency, flap monitoring, the drain output or the whether there's any localized swelling. Then pulse rate. Patient can have tachycardia. That can be due to many reasons. It can be due to pain. It can be due to hypovolemia. Then it can be due to any if he is intubated and he is conscious. So that can be a source of irritation and can cause tachycardia. So you have to completely evaluate the cause of tachycardia and accordingly manage. Then you should have a look at the saturation of the patient, the blood pressure, input output charting, the medication chart. You have to check whether all the medications have been given, and you have to check the post of day 1 investigation. So the hemoglobin, the electrolytes, and the WBC count. This is generally we should always check in each and every patient. So ICU admissions, when does the patient require more days of ICU and not for 1 or 2 days when he's having respiratory failure requiring ventilatory support, when he's having organ failure due to underlying comorbidities, when there's any organ decomposition due to requiring critical care consultation, hemodynamical instability, when his BP is not getting controlled in spite of fluid replacement and patient is on noradrenaline, and when there is need for diagnostic or therapeutic bronchoscopies due to any pulmonary insufficiency and when he is not maintaining saturation. So generally ICU they calculate something called as a frailty index. So that has got 15 variables which helps in prediction of critical care support in head and neck resections, especially for free fall. So this is a paper by Nicholas. You can all have a read on this. Then airway patency. So the most important clinical goal in the immediate post-op period. It is different for tracheostomized patients and intubated patients. Elective tracheostomy is preferred when you have got prolonged intubation is anticipated and when the support to the laryngeal framework is lost. So in middle third mandibulectomy, when you have loss of arch, in tongue resections, when you the tongue, the supraheart muscles you have cut, so that the tongue support is gone. So in those cases, we will do a tracheostomy, and tracheostomy but is associated with other complications. So tube obstruction, lower respiratory tract infection, then delayed oral intake. All this can happen. So we should all keep that in mind. So in intubated patients, we should know when is the ideal time for extubation. So a planned intubation and mechanical ventilation has been followed, and generally we follow that the extubation is done in post-op day 1 after ensuring his vitals, his flap is healthy, and the patient is completely conscious. There are papers which have shown, like this one by Amir et al., which has said that immediately doing post-operative extubation in free tissue transfer patients. So this is a retrospective study. So they compare two groups. One is an immediate group, while is a delayed group in the ICU. There were total of 26 patients in each group. This was done in around 2009 to 2010 years, and they saw that the average ICU stay for the immediately extubated group was significantly shorter than the delayed group, and a reduction in overall stay did not achieve any statistical significance. Only the ICU stay was shorter, but overall hospital stay was not difference was not seen. However, they commented that immediate post-operative extubation following free flap transfer reduces the ICU stay, anxiolytic use, I mean drug use, and incidence of pneumonia also decrease without any increase in flap or wound related complications. So they said that taking individual patients into picture, we can do an immediate extubation on the operation table. However, the immediate or delayed extubation should be individualized based on patient-related factors, surgical factors, expert of the anesthesiologist, and available resources. So this was their final conclusion. Then, why tracheostomy is considered slightly better than translaryngal intubation? Because tracheostomy patient can be mobilized, they have a more secure airway, the patient is more comfortable for obvious reasons. If the improved airway suctioning can be done to a tracheostomy. Early transfer of ventilator-dependent patients from the ICU, then less direct endolaryngeal injury to our vocal cords, enhance oral nutrition, phonation, and communication, and decrease risk for pneumonia in patient subgroups. So, a few slides I would like to speak on the tracheostomy care. So, what are the physiological effects of tracheostomy? So, there is reduction in dead space. So, you are bypassing the whole airway, right, from your nasal cavity till where the tracheostomy tube is in place. So, the laryngeal bypass, nasoclearance and humidification is lost. So, that's why it's important for the humidification, and we tell to keep that wet bib in front of the tracheostomy because it can get easily dry. Then there's a redundant area between the stoma and larynx. So there can be air loss, and which it can cause subcutaneous emphysema, and there can be disruption of normal swallowing mechanism. So these can all be the physiological effects of tracheostomy. So generally, initially we put a cuff tube for the patient. So as you can see in this picture, when the cuff is inflated, there's a seal at the side of the tube so that whatever secretions or blood is there in the trachea does not seep down, and it does not cause any further complications. So when you can anticipate tube trouble, when the patient has got like increased breathing efforts, or the patient is confused or aggressive, then whenever patient is able to speak without occluding a tube, that means there is some obstruction in the tracheostomy because of which air is able to pass through and come out through his larynx. Then is the breathy noisy? That can be because of wet secretions or dry because of crusted mucus. And whether you can pass a suction catheter. So if the suction catheter is not going beyond 7 to 9 centimeters, that means there is a blockage in the tube. Then tracheostomy tube change. So ideally it should be done after 48 hours. So because when we do an upfront tracheostomy, we anticipate bleeding. So that blood can get clotted, and many a times those clots don't come out easily. So generally a protocol should be followed that after 48 hours, the tracheostomy tube should be changed because even the tract is formed. It's completely epithelialized in that 48 hours, and bougies or guide wires should be used generally. So that is called as a railroad technique. So I'll just explain how it is done further. Then wound care is very important. So around the tracheostomy, you should place the gauze piece. So a small V-shaped cut should be made in the gauze piece, and it should be passed below the tube and placed in between the skin and the tube. Because if you one important thing is it helps the tracheostomy to be in place, and second, any irritation between the tube and the skin is prevented. So there is no localized erythema or edema, and there is no further complication. So, suctioning is very important. So, while suctioning, we have to first initially clamp the suction catheter, pass the tube inside, and then release the suction catheter and slowly take it out. So, why is this important? Because generally, when we initially pass the tube without obstruction, they say that whatever air is there, patient can have difficulty in breathing because the suction catheter also like removes that air. So that's why it is important to clamp the suction catheter and put it inside. Then the cuff of the tube should be deflated for every 5 minutes in every 2 to 3 hours because it can cause pressure necrosis of the tracheal wall. So patients having long-standing tracheostomy tube, they should be counseled that in every 3 hours the cuff should be deflated for 5 minutes and then re-inflated. The tracheostomy should be fixed for the first 48 hours with the sutures, and in free flap patients also sutures are ideal, and then we can replace it with a tape later if the sutures become loose. Humidification is necessary, as I mentioned earlier. Then decannulation should be done in a stepwise manner. It can be done when you feel that the patient has condition has improved, and you can do half or full corking. Half corking where you put a like just a half the opening of the tracheostomy tube is left behind. So because some patient may not tolerate full corking, and if patient is not tolerate corking, another way to try decannulation is by downsizing of the tube. So instead of a 7.5 tube, we put a 6 size tube. Because in a 6 size tube, there will be surround, when we cork the tube, there will be space between the tube and the trachea, through which patient will be able to breathe. Next important content in our indoor management is analgesia and sedation. So, what painkillers needs to be given to the patient? So, generally we give paracetamol or diclofenac, but some patients may need more severe pain management. So, in those we should try other drugs like ketamine or gabapentin. Gabapentin is generally given for neuritic pain. We should generally try to avoid opioids. This is what is said because opioid has got its own side effects. Flap monitoring. So intensive monitoring of the flap should be done in the first 24 to 48 hours because this is the time that most complications are noted. Early recognition of the compromised flap perfusion would help in early intervention so that the flap can be salvaged. So it can be done by bedside clinical examination, looking for capillary refill, temperature of the flap, whether it is warm or cold. Then the flap color. So if it is congested, you will see that blue tinge because of venous condition. Or colored Doppler can be used for the first 24 to 48 hours. This can be complemented with a pin prick test. So generally nowadays we avoid this pin prick. We take use of other parameters, and the head should be maintained in a neutral position. So when the anastomosis is done, we should see in what plane the vessels are lying, and accordingly we should keep the head in that position so that there is no like kinking of the vessels which can compromise the vascularity of the flap. So when after the surgery, we can mark the points of these perforators, and this is how then the Doppler can be done, and we can assess the viability of the vessel, the anastomosis. Then coming on to fluid replacement. So optimal fluid therapy should be given to ensure normovolume and normotension. So this should be our goal in these post-surgical patients because hypervolemia can lead to tissue edema while hypovolemia can cause flap thrombosis. Tissue perfusion and efficient central hemodynamics. So the vital should be maintained. So generally we use 4 ml per kg per hour as the maintenance fluid replacement. So in the post-op day 0 and 1, when the patient is not started any oral or RILQ feeds, we have to give fluid replacement. So 4 ml per kg per hour is our general maintenance fluid. And we generally use ringolactate, that is RS. Crystalloids are used as a maintenance therapy in severely hypovolemic patients, while colloids are used as an acute fluid replacement. So when there is blood loss, but the hemoglobin has not fallen, you don't think will fall below 9, but patient requires fluid, you generally give crystalloids and colloids. And if hypotension continues despite your fluid management, you have to give then vasopressors, so noradrenaline static, so that you can at least keep mean arterial pressure to minimum 70 millimeters of mercury. Then nutrition. So you know that patient will be nutritionally depleted prior to surgery also, and resumption of oral diet can be delayed, further affecting the nutrition. So we have to start enteric polymeric enteral feed. Feed started slowly at the rate of 20 ml per hour and gradually increase. So we can give up till 250 to 300 ml of RT feeds 2 hourly. So that is the general we follow from the post-operative day one. And studies have shown that early feeding after free-flap reconstruction, or even that is oral intake and not trial tube intake, has not been associated with any increased morbidity or outcome, and a shorter hospital stay may favor the adoption of an improved recovery program. So there have been studies showing that. Then coming on to DVT prophylaxis. So head neck surgical patients have considerably higher rates of venous thromboembolism with nearly 20% in highest risk subgroups. It has been shown to be associated with increased length of hospital stay by more than 5 days and 6.56% excess mortality rate. What are the risk factors for venous thromboembolism? So malignancy, pulmonary comorbidities, large and complex surgeries, age, advanced age more than 60 to 65, male sex and obesity when BMI is more than 25. But there is a concern of hemorrhage, so we have to take opinion and start. So both the NICE and ASCO guidelines have shown that we should use pharmacological thromboprophylaxis for a minimum of 7 days in patients in whom the thromboembolism risk is more, and it should be in the form of lower molecular weight fractionated heparins or ultra fractionated heparins. So we generally use Clexane. So the doses for like a well built patient, 0.6 cc subcutaneous once a day, and in averagely built or a low built we use 0.4. Then coming on to ward assessment, so the checklist important to be followed is first speak with the patient, ask his symptoms and his problems. Second is do a clinical examination of the patient, so flap monitoring, localized swelling or collection, and the donor site wound. Then look at the drains, the blood pressure of the patient, the temperature charting, any fever, input output charting. The hemoglobin and electrolyte should be repeated every 3 days because electrolyte imbalance can be done because patient is not taking normal diet, and HGD charting should be done for diabetics. So drain management, so look at its output. So generally we have from post-op day 0 to 2, it generally increases. It can go up till 150 to 200 and then gradually it comes down. More than 200 drain output we can see because in an obese patient or because of any salivary leak, that is parotid fistula. We can see because of orocular fistulas where there can be a communication between the oral cavity and the neck, and because of Kylie, but that will the drain will have a milky nature, so you will know that it is. Then color, generally it transforms from a sanguineous, that is the bloody nature, to serosanguineous and serous. So we can see how it progresses from day 0 to day 7. Drain should be charged adequately, then only it is of use, and declotting should be done at least once a day. If the tube is drained, the tube is blocked, then there is no role of that drain. An important concept is rehabilitation. So there should be early initiation of speech therapy, at least from day 2 of surgery, as well as following exercise. So generally we follow from day 3 to 4, we start certain oral sips of water for the patient. Swallowing exercises can be started because it helps compensate in changes in the anatomy and physiology of the patient and reduce the risk of aspiration. So few postures like chin tuck, head turn. So this will all be explained. So we have a talk on swallowing exercises also. So Yasha can later speak on it. And post-operative chest physiotherapy can be given because it helps in reducing the built-up secretions in the chest and reduces the length of hospital stay. And now coming on to perioperative antibiotic therapy. So the our incidence of surgical site infection in clean surgeries is less than 1%. In clean contaminated surgeries, it is 24 to 48%. So we have to have a rational use of antibiotics. In clean surgeries such as thyroid, parotid, and all, antibiotic coverage other than that single dose during surgery, further antibiotic is not recommended. But for oral surgery, it should be continued. So the current hospital, our policy is injection Supasep. So we have to all stop using augmentin. Okay, even now we for sir and we have started giving Supasep and Metro, but even for Pradhan sir's patients also, because the hospital policy says injection Supasep should be the considered as the first choice, and in our major surgeries, oral cavity surgeries, metronidazole should also be used. Injection augmentin being a broad spectrum antibiotic should only be used as a reserve. And if there is a fever, we should send the further relevant investigations and change the antibiotic only after we have a proper culture or a antibiotic sensitivity. And if the antibiotic has been changed, we should inform it to our infection control committee. So to conclude, head and neck cancer patients can pose unique challenges in the ICU requiring close monitoring for early recognition and prompt management. A multidisciplinary approach helps to achieve the best and faster recovery, and the 10 task of OPD evaluation should be borne in mind. Thank you. Any questions?